All right, so welcome everyone to the Health and Nutrition Sciences speaker series. Today we have Allison Brown, who is from NHLBI, National Heart, Lung, and Blood Institute, one of the 27 institutes and centers at the National Institutes of Health. And Allison Brown, when we signed you up for this talk, your credentials were MS PhD, but I have to congratulate you that your credentials are now MS PhD RDN, which is super exciting. So congratulations on that. Allison is, I should say, Dr. Allison Brown is a public health nutrition researcher who's committed to addressing diet-related health disparities through research, community empowerment, and systems change. And Dr. Brown's past research explored immigrant health and diet and cardiovascular disease outcomes. And currently she serves as program director at the National Heart, Lung, and Blood Institute, where her work centers on the social determinants of health and nutrition health disparities. And that's what her talk is going to be addressing today. She also served as the past chair of the National Organization of Blacks in Dietetics and Nutrition, also known as NOPADAN, and as adjunct faculty at Prince George's Community College. She is a former AAA Science and Technology Policy Fellow, which is how I met Allison at the NIH. She's also a former Academy of Nutrition Dietetics Diversity Leader, American Society of Nutrition Science Policy Fellow, and board chair of a community-owned grocery store in Boston. And in 2018, she was honored as a 40 under 40 leader in minority health by the National Minority Quality Forum. And she also serves on the editorial board for the Journal of Immigrant and Minority Health, the Journal of Racial Ethnic Health Disparities, Health Psychology, and Translational Behavioral Medicine. And you may also have heard that Dr. Allison Brown is collaborating with a number of the people we know, notably Kate Burt, Dr. Kate Burt from Lehman College, who spoke to us a few weeks back, and our own Dr. Melissa Fuster. And so the network is quite small in public health nutrition, and it is quite rich with women researchers and minority women researchers who focus on some of the fundamental problems that we clearly need to address. So the way of the format today is that we will listen to Dr. Brown's presentation, and then we will switch over to questions. You're welcome to type your questions in the chat, but we will take questions unless Dr. Brown wishes to do so in the middle of the talk. We'll take questions at the end. So welcome again to the Brooklyn College Health and Nutrition Sciences speaker series and Dr. Allison Brown.
Thank you, Marguerite. Thank you for that warm welcome, and thank you to the organizers for the invitation. I'm really excited to present on the topic of nutrition health disparities and social determinants of health, with a specific emphasis on racial ethnic health disparities. So I wanted to start the presentation with my video on, but I will turn it off for issues of bandwidth, but we'll turn my video back on during the Q&A period. So bear with me as I turn my video off. Okay. So to start, I do want to state the disclaimer. So the views expressed in this presentation are my own and do not necessarily represent the views of the National Heart, Lung, and Blood Institute, the National Institutes of Health, or the U.S. Department of Health and Human Services. So to start, I just want to provide a brief overview of my presentation. So I'll quickly outline the racial, ethnic, nutrition, and diet-related health disparities that we see in the U.S. context. And then I'll specifically, through the remainder of the presentation, talk about social determinants of health and their impact on diet. So particularly education, economic stability, neighborhood and built environment, health and healthcare, social and community context. And then I'll end with policies and programs to address nutrition health disparities and some work that we're doing here at NIH, as well as some essential takeaways from the presentation. So to start, I'll share an overview of the racial ethnic disparities observed in diet-related diseases in the US. Overall, Blacks and Hispanics experience higher rates of obesity compared to their white and Asian counterparts, with the disparity more apparent in women and men than in men. And Blacks are also more likely to die of heart disease, and although the trends have declined over time, Blacks still have the highest death rate more than any other racial group, as depicted here in this graph. Similar trends are shown in rates of hypertension and type 2 diabetes. And as I'll demonstrate in the next slides, there are several root causes to the disparities we see. So in his provocative New England Journal of Medicine piece, We Can Do Better Improving the Health of American People, it was posited that most premature deaths in the US are not caused by healthcare or genetic predisposition, but instead mostly on behavioral patterns, as this image demonstrates. But as you'll note, there's a severe and comprehensive interconnectedness between these social circumstances, environmental exposures, and then healthcare access and their influence on behavioral patterns. So in this presentation, I will argue that behavioral patterns, particularly diet in this context, are shaped by these different circumstances in the healthcare, environmental exposures, and so forth. So I want to start off with dietary behaviors in particular, and what does the literature say regarding dietary intakes by race and ethnicity? In an analysis using NHANES data from 2011 to 2012, the findings demonstrated glaring disparities in intakes of many different food groups. And as you'll note, Blacks consume less whole fruit, vegetables, nuts, and seeds, meanwhile consuming more total meat, sugar, sweetened beverages than their white counterparts. For the Mexican Americans in the sample, they consume less vegetables and more meat and sugar sweetened beverages than their white counterparts. For additional nutrients such as added sugar and sodium, most notable is the greater consumption of added sugar beverages or added sugar, intake among Blacks. So the key question when presented with all this data is what is driving these food choices and differences in food intakes by race ethnicity, which brings us to the social determinants of health and their influence on dietary choices. So the premise set forth by Healthy People 2020 and 2030 in their social determinants of health framework is that health is not solely determined by your genes or seeking medical care, as previously mentioned, but also social conditions of where you work, where you play, and where you live. These are the 5 domains as outlined in Healthy People 2020 and 2030, and they impact nutrition based on availability of food or indirectly based on its influences on economics and resources. It should also be noted that these domains are interconnected. And whether we would like to admit it or not, and some organizations and institutions are more progressive in this area than others, embedded in each of these domains is the lingering influences of structural racism and bias and discrimination, which I will also mention throughout my talk today. So multiple components of education, including the level obtained and the quality from K through 12 education, impact dietary choices. And as mentioned, the economic resources available to purchase healthful foods is another factor worth noting. Directly related to diet, of course, is the notion of nutrition literacy, which includes a person's understanding of the nutrition facts label, the meaning of values such as percent daily value in front of package labeling, such as cholesterol-free and high in fiber. But in the literature, nutrition literacy is shown to be associated with better diet quality, but no research has been conducted to compare nutrition literacy by race and ethnicity. And while nutrition literacy is certainly important, it is not the entire picture. I will focus instead on focus my attention on access to quality education throughout the life course and its long-term influences on someone's resources and earning potential. Inequities in education are systemic. In many marginalized communities, systemic racism has resulted in limited access to well-resourced neighborhoods and quality education. This includes access to adequately funded schools, given that school funding is often derived from property tax values. Insufficient funding results in fewer resources to support not only learning activities, but also student health and safety, as well as teacher support, which can lead to negative physical and mental health outcomes. This in turn has a ripple effect on educational attainment. Systemic racism also infiltrates education as early as preschool. Research shows that Black students are much more likely to be suspended from preschool than white students. Black students make up only 18% of all preschoolers, but represent almost 50% of all preschool suspensions. Implicit biases within educators of our education system ultimately has an impact on long-term achievement outcomes among racial ethnic groups. You'll note in the next slides the interconnectedness of education and income. So this slide, for example, shows the percent distribution of educational attainment by race ethnicity, and it demonstrates these disparities. As you'll note, whites and Asians have the highest percentage of bachelor's degrees or higher. Meanwhile, minorities such as Blacks, Pacific Islanders, and American Indians have the highest percentage of high school only, and Hispanics have the highest percentage of having less than a high school education. As I will show in the next slide, this relates to potential earnings by race, ethnicity, and the economic resources allotted for maintaining a healthy lifestyle. So this graph, based on data from 2016, shows the median annual income of workers aged 25 to 34 by both educational attainment and race ethnicity. For the most part, whites earn more annually than every other racial ethnic group at every level of education. The exception, you will note, is those with a bachelor's degree or higher, in which Asians make more on average. Although the graph isn't shown, based on median income data by race of all educational backgrounds, Blacks and Hispanics earn approximately $11,000 less annually than their white counterparts. This translates to whites earning more than $100,000 more over a decade than their Black and Hispanic counterparts. But again, these are averages. In spite of anti-discrimination and equal pay laws, these inequities by race persist. Related to educational attainment and income by race ethnicity is student loan debt by race and ethnicity. Again, to be holistic in the social factors that influence diet and lifestyle, I think it is important to note. On average, Blacks are more likely to have education debt than other racial groups. Nearly 40% of Blacks have student loan debt compared to approximately 30% of whites and Hispanics. But to complete the picture is a matter of how much debt. There are additional differences in the amount of loan debt by race ethnicity, with Blacks having on average $45,000 of loan debt compared to around $30,000 for their white and Hispanic counterparts. Note that these are averages and not medians, so there's definitely potentially a wide distribution in these figures. So overall, a large percentage of Blacks have student loan debt and of greater amounts than other groups. And although not shared graphically, generational wealth contributes to increased support for education from family. Home ownership in particular has historically been an important means for Americans to accumulate wealth. For context, in the first quarter of 2020, the Census Bureau reported that Black households had the lowest homeownership rate at 44%, nearly 30 percentage points behind white households. Historical practices and racial discrimination within America's housing system, including the denial of home loans, has undermined wealth accumulations among communities of color. So now I'll move on to economics and economic stability, which directly impacts diet given the overabundance of cheap, fast, and processed food in our food system. Energy-dense and nutrient-poor foods that contribute to diet-related diseases such as diabetes and heart disease are lower in costs compared to healthy foods. For an example, an apple is more expensive than a McDonald's Big Mac on the dollar menu. And additionally important is the precious resource of time, which we often overlook in the discussion. Work type and time availability contribute to the amount of time a person has to prepare home-cooked meals. The working poor and those who have demanding jobs often may not have the time to devote to cooking foods at home, which is shown to be better quality than takeout food or prepared processed meals. I show the cover of this book, The Working Poor, by the Pulitzer Prize winning author David Shipler, because it highlights working American families struggling to escape the poverty system. Minimum wage has not kept pace with the cost of housing and living expenses in this country, making it challenging for working families to make ends meet. Which brings us to household expenditures. How much do people actually spend on food? So one looming assumption is that overall financial and economic resources equates to less resources for food and maintaining a healthy diet. So what does the data show on food expenditures? The U.S. Bureau of Labor Statistics tracks household level expenditures by race ethnicity in various categories, as shown here. Note that loans are not included in this list, but rather expenses related to the household. These range from housing expenses to transportation costs and food. And as noted here, Blacks and Hispanics spend less overall in household expenditures and also less in dollars on housing, food, transportation, personal pension, and insurance, and several other categories. Since this parallels income overall, an even more important perspective is how much how much these numbers are as a percentage of total household expenditures. As shown in this graph, a percentage of total household expenditures, Hispanics, Blacks, and Asians spend a greater percentage of household expenses on housing, with housing expenditures making up 36.8% of total household expenditures for Black or African American households. Specific to impacts on diet, Hispanics spend more on food and Blacks spend a slightly higher percentage of their total expenditures than whites and Asians. And although empirical, this data supports the notion that income is associated with food expenditures. This brings us to food insecurity, which of course directly links economic stability to diet and diet quality. Measured at the household level, the USDA defines food insecurity as a limited or uncertain access to adequate food, which relates to income and financial resources. Research shows that those who are food insecure have poor food diet quality than those who aren't. And this is no surprise given the overabundance of cheap processed food in our food supply. Based on 2019 data, food insecurity is higher among single parent households, particularly those headed by women, as well as non-Hispanic Black and Hispanic households. More broadly is the income inequality by race, ethnicity overall, which again impacts the allotment of resources that goes toward food expenses. So in summary, how does education and economic stability influence diet? Directly related to nutrition, someone's knowledge and understanding in nutrition, also known as nutrition literacy, can influence diet, but more research is needed on nutrition literacy by race ethnicity in order to inform the development of appropriate interventions. More broadly, however, systemic racism and implicit bias embedded in our education system, starting as early as primary education, play a role into overall educational attainment by race ethnicity and ultimately income. Racism and bias within our labor system also plays a role in income inequality. Income and education disparities by race ethnicity have implications for food choice based on availability of resources, particularly financial resources and time resources. So next, I'll move on to access to healthcare and quality of healthcare, which is another factor in shaping health. Specific to nutrition, registered dietitians are licensed to provide medical nutrition therapy in outpatient and inpatient settings. And if a person lacks health insurance, this could cut them off from receiving this type of care. The quality of care and cultural competency of the workforce is also important to consider. So to start, the first social factor to note is the difference in insurance rates by race ethnicity, which has implications for the time of diagnosis and treatment of diet-related diseases. This graph shows trends in rates of uninsurance by race, and you'll note that based on the most recent data, American Indian and Alaskan Natives are the most uninsured, followed by Hispanics at 19% and Blacks at 11.5%. Again, this has implications for access to care since those who are uninsured are less likely to seek preventative services and seek care from a primary care physician. Next, we have the factor of how people of color are treated in the healthcare system. In 2003, the Institute of Medicine released the report Confronting Racial and Ethnic Disparities in Healthcare. As the report found, minorities receive poorer quality of care in terms of treatment and procedures than their white counterparts. Although physicians go into the healthcare system with good intentions to treat patients, interpersonal racism and the implicit bias that we all have plays a role in contributing to the disparities we see. While this report was published in 2003, these realities persist today. Most notably, given its recent news coverage, is the high rate of maternal morbidity and mortality and infant mortality among Black women in the US, which parallels or is worse in some developing countries. So I want to also turn our attention briefly to the dietetics profession, given that there is a strong lack of diversity in registered dietitians. Based on self-reported data from the Academy of Nutrition and Dietetics Commission on Dietetics Registration, only 2.6% of RDs are Black, 3.1% are self-reported to be Hispanic, 3.9% are consider themselves Asian, and an overwhelmingly consider an overwhelming 81.1% consider themselves to be white. This is important since racial concordance of clinical professionals is arguably important for care, and all the more reason why cultural humility is important for dietetics training. So now I'll shift gears to where someone lives and their neighborhood and built environment and how that influences someone's diet. In rural communities, grocery stores are sparse and people may need to drive miles to access food. And these are called food deserts. And while food deserts are most common in rural communities, they also occur in urban and suburban communities as well. Food swamps, where there is an overabundance of fast food outlets, are commonplace in urban and suburban communities of color. Urban neighborhoods often include an abundance of corner stores with limited availability of quality and affordable produce and healthy foods. Racial segregation in urban communities is also an important influence, and as demonstrated in the next few slides, the systemic racist practice of redlining has had its lingering effects on segregation throughout the U.S. And although I do not discuss this thoroughly, environment in the workplace and in schools also determines what's available to eat. And also a consideration is place of work and type of work and how that influences the time and ability to eat regularly throughout the day. So for the next few slides, I'll focus on how where you live influences resources to maintain a healthy diet and lifestyle. The images here are redlining maps of New York City, as you guys might find familiar, Oakland and Minneapolis. And again, the 1930s housing policy known as redlining had a very major effect and racial implications to this day, even after it has been outlawed in the 1960s. It really continues to have lasting effects on social and community boundaries. And specifically, redlining was the practice of denying mortgages to people, mostly people of color, in certain neighborhoods. So again, its scars remain visible in many communities across the U.S. today. And in these images, blue represent the Black population, red dots represent the white population, yellow dots represent the Asian population, and green represents the Hispanic population. So from Washington, D.C. to Chicago and Houston, racial ethnic segregation is commonplace, and this is common again in many cities throughout the U.S. Many of you guys may have seen this Robert Wood Johnson Foundation report, and it showed how much place matters when it comes to health based on life expectancy. So place and where someone lives, which is impacted by racial segregation, and it contributes to unequal allocation of resources at the individual, family, and community levels. And ultimately, these inequitable distribution of resources result in poor health outcomes that persist today. If you've lived or traveled throughout the U.S., these are very notable. Where I went to school in the Southwest Atlanta area at Spelman, it was riddled with fast food restaurants from Bojangles, Taco Bell, you name it. Yet if you drive or take the MARTA, that's the public transportation system, if you take it 5 stops to Little 5 Points or Buckhead, and it's a completely different experience. So the influence of redlining on food access and community resource allocation has been well documented in the research literature. In fact, the term retail redlining has been represents the differences in retailers by community and the discriminatory practices among retailers of not serving certain areas based on their ethnic minority composition. Consumers in these areas often find themselves vulnerable to being exploited by smaller retailers who charge higher prices and or often more inferior goods. The article here describes 7 specific types of retail redlining practices. And the additional study looks at retail redlining, particularly in New York City. And while these are focused on retailers more broadly, a small literature also documents this related to supermarkets. And a term that this research coins as supermarket retailing. So lastly, I will end by discussing how one's social experiences, networks, and community contributes to dietary choices. So cultural upbringing and the foods that you were raised on play a role into your dietary preferences. But beyond this is also the Western culture and how this influences diet. Stress and exposure to discrimination can also arguably contribute to stress eating and other coping behaviors. So when we think of food culture of the groups mostly impacted by diet-related diseases, in many cases the foods are actually abundant in fruits and vegetables. Many cultures have strengths in their cultural diets. The culture that I want to focus on is the westernized culture in which fast food, sugar-sweetened beverages, oversized meals are more pervasive. Time-constrained individuals and families rely more and more on takeout food than home-cooked meals. Because of economic constraints, those of lower socioeconomic status, who are often time constrained, are reliant on these different food options. This is compounded by what is available in one's neighborhood and community. Marketing of our sugar-sweetened beverage industry have also become pervasive. And over the past 20 to 30 years, serving sizes have ballooned, increasing intake of not only calories, but also saturated fat, sodium, and refined grains. A link to this is the increased advertisements to Black and Brown communities. So a 2015 report published by the Rudd Center for Food Policy and Obesity in collaboration with an organization called ACORN, which is the African American Collaborative on Obesity Research, and as well as Salute America, they found that compared to white non-Hispanic youth, Black and Hispanic youth are exposed to more food advertising in the media as well as more marketing. And my apologies if you hear background noise. So again, this study by the Rudd Obesity Center found that Black and Hispanic youth are exposed to more food advertising in the media, as well as more marketing messages in their communities. And although the researchers did not conduct a nutritional analysis of the targeted brands, most of the advertising targeted to Hispanic and Black consumers promoted food and beverage product categories comprised primarily of nutritionally poor products. In our capitalistic society in which businesses are free to target the most marketable and lucrative consumer, quote unquote, one has to ask which comes first and what is ethical. What influences what? For example, Black and Hispanic youth are known to consume more sugar-sweetened beverages than their white counterparts, but you must ask yourself, what is the influencing factor in this behavior? This practice may not be overtly racist, but it demonstrates how organizational practices do not integrate a health and racial equity lens. So another social factor that I would be remiss to not mention is the policing policies and practices within this country. The killing of Black men and women is an overt way that interpersonal racism plays out in our system, but the disproportionate incarceration of Black and Brown men and women is a noteworthy structural form of racism that is embedded in our policies. The three-strike law policy, for example, is included a stronger sentencing for crack cocaine compared to cocaine in the 80s and the early 90s, even though they are made from the same addictive substances. This is an example of another way that structural racism persists in policies and practices. And I bring this up in the context of diet-related diseases because of its relationship with the destabilization of the household. If a father or a mother, for that matter, is incarcerated and can no longer provide financially for his or her family, this destabilizes the household, contributing to time constraints of the single parent and resource constraints to provide for their family. This is evidenced by the higher rates of food insecurity among single parent households. And I mention this not to perpetuate stereotypes of the absent father paradigm, but mention it to demonstrate how systemic racism in practice and policy seemingly unrelated to the nutrition field, in fact, contribute to diet-related disparities. So, and lastly, I'll end by mentioning the impact of psychological stress. Stress and elevated cortisol rates are known to be associated with poor health outcomes, and the concept of allostatic load, for example, is the accumulation of stress over time. It's been shown to be higher among racial ethnic minorities. In terms of the exact link between race, ethnicity, and stress and its direct link to diet, more research is needed in this area, particularly around emotional eating, skipped meals, and binge eating as well. A few small studies among Native Americans and African Americans have demonstrated a link between racism-related stress, trauma, and binge eating. But overall, the influence of stress on dietary practices and diet quality is noteworthy for future studies. So now I will turn gears over, now that I've covered the background and context of how various social determinants of health influence diet. I'll end with discussing a few policies and programs to address these disparities shown in diet-related diseases. So first, I would like to mention a few federal level policies to address nutrition-related disparities. Programs such as a Supplemental Nutrition Assistance Program, Women and Infant and Children Program, the Federal School Lunch Program, and the Federal School Breakfast Program are income qualifying programs which help to address socioeconomic disparities and provide a safety net to address food insecurity in the US. So SNAP is the nation's most important anti-hunger program. It reaches about 38 million people nationwide, and this is based on 2019 data. So as you can imagine, these numbers have grown substantially throughout the COVID-19 pandemic. The GusNIP program, it aims to encourage fruit and vegetable consumption among SNAP recipients by providing incentives at the point of purchase. And the 2018 Farm Bill authorized the program for fiscal year 2019 to 23, and the growth in the program has increased from 45 million to 56 million, which will be appropriated over a 5-year time period. So WIC is the third largest food and nutrition assistance program, and it serves about 6.2 million participants per month. And this is based on fiscal year 2020 data. And this program targets women and infants and children, and it included in 2020, almost half of all infants born in the US participated in this program. And then the federal school lunch program, based on fiscal year 2019 data, operated in nearly 100,000 public and non-profit private schools, K through 12, as well as residential childcare institutions, and they provided low cost of free lunches to nearly 30 million children daily. And lastly, the school breakfast program in fiscal year 2019 served 14.7 million students, which was virtually unchanged from previous years. Overall, these programs aim to address the nutrition needs of the most socioeconomically vulnerable in the US. So next, I'll provide an example of a city-level policy, which is the South LA fast food ban. So in 2008, the LA City Council approved a 1-year moratorium on new fast food restaurants in a low-income area of the city in an attempt to attract restaurants that offer healthier food choices. And at that time, nearly 3/4 of the restaurants in South LA were considered fast food outlets. Unfortunately, this policy was a failed attempt to reduce fast food consumption or reduce obesity rates. And according to a 2015 RAND Corporation study, based on data from the California Health Interview Survey, the study showed that fast food consumption and then rates of overweight obesity actually increased from 2007 to 2011, 2012 in all different areas surrounding the LA City area. And the increase in the combined prevalence of overweight and obesity since the ban was also significantly larger in South LA than elsewhere. So one could argue that this unidimensional approach failed to account for the other factors that drive behavior, and that eliminating growth of the fast food sector alone is not enough to change behavior. So the next program is an example of trying to improve, yet another example of trying to improve the neighborhood food environment. And just for more background, in 2004, the Food Trust piloted the Healthy Corner Store initiative with the goal to motivate youth and adults to purchase healthier items through classroom education, as well as direct marketing in the corner stores. And since then, the initiative has grown substantially, and it involves several partners within the Philadelphia area. So the Philadelphia Department of Public Health, they have partnered with this initiative through the Get Healthy Philly initiative, with additional financial support from the Pennsylvania Department of Community and Economic Development, Representative Dwight Evans and the Philadelphia Department of Commerce, as well as AstraZeneca's Healthcare Foundation and the Jefferson Center for Urban Health. And it includes a multifaceted approach. So it increases store capacity to sell and market healthy items in order to improve healthy options in communities. It also offered training and offered technical assistance to store owners to provide the skills to make healthy changes profitable. It also helped to market healthy messages to youth and adults to encourage healthy eating choices. It also hosted in-store community nutrition education lessons, as well as education of youth in schools nearby in order to reinforce healthy messages and provide nutrition education through the Snacking Fresh program. In addition, it linked corner store owners to community partners and local farmers and fresh food suppliers to create and sustain healthy corner stores. So this is an example of like really using a multifaceted approach and all of the different aspects that impact behavior. So the next two examples include programs to improve the quality of foods in our charitable food system. So the first example is the Minnesota-based Super Shelf program. And this is an NHLBI funded study that aims to transform the food pantry shelves by applying the behavioral economic strategies to make the healthy choice the easy choice by placing healthy food options in prominent places throughout the food pantries. Shown here is a before and after photo of one of the participating food pantries. And the effectiveness of the intervention, like I mentioned, is being funded by NHLBI, and Dr. Caitlin Caspi is the investigator leading this project. And again, the goal of the study, specific goal rather, is to determine the impact of the intervention on BMI and diet quality of the food pantry patrons. And the study findings are still being determined, but this is a promising approach to address the food quality and potentially the health outcomes of those utilizing the emergency food systems. So the next example is through the Healthy Eating Research Center through the Robert Wood Johnson Foundation. And this organization convened a panel of experts in the charitable food system, as well as the nutrition and food policy fields. And the goal of the convening was to create clear and specific recommendations for evidence-based nutrition guidelines in order to improve the quality of foods served in food banks and food pantries. And given the expertise around the table, the recommendations were particularly tailored to the unique needs and capacity of the charitable food system. So the Healthy Eating Research Group is currently in the process of evaluating the impact of implementing these guidelines in participating food banks and pantries. So one of the final programs that I wanted to highlight is one including a multi-level and multi-institutional approach. Again, because of the complexities and interrelationships of the root causes of health disparities, addressing them warrants a multifaceted whole of community approach. So transforming communities is an initiative of Trinity Health, one of the largest multi-institutional Catholic healthcare delivery systems in the nation. And this 5-year, $80 million initiative consists of grants, loans, technical support, as well as community matching funds and other activities aimed at improving community health and well-being. And the initiative particularly targets 3 specific areas, including obesity, tobacco-free living, and then relevant to this talk, social determinants of health. So I thought it worth mentioning an example of kind of this trans-institutional, multi-institutional, and multifaceted whole community approaches. So another example that I wanted to highlight is a policy that has the potential to impact health disparities is an increase in the minimum wage. So according to a recent Pew report released earlier this year, 21 states follow the federal minimum wage rate of $7.25 an hour, and workers in other states, including New York, receive more gratefully. The map on the right indicates where U.S. cities and counties have implemented their own local minimum wage laws to keep pace with the rising costs of living. So I wanted to highlight this innovative study. It's called the Wages Study, and it's an NIDDK, or that's the institute that focuses on kidney diseases and digestive disorders. So this is an NIH-funded study examining the impact of minimum wage on health. And specifically, the 5-year study aims to evaluate the effects of a minimum wage increase in Minneapolis on the health and body weight of low-wage workers. And the study design uses a quasi-experimental natural experiment design. And the study will compare the changes from 2018 to 2022 in outcomes between city workers in Minneapolis compared to those in Raleigh, North Carolina. And these 2 cities have similar baseline characteristics. That's why Raleigh, North Carolina was chosen as the control group. And particularly, Minnesota recently implemented an incremental increase in their minimum wage. Conversely, North Carolina has a state level preemption against local minimum wage increases, making it an ideal control group. And while this study is ongoing, preliminary findings show a decrease in the percentage of those experiencing food insecurity between these two different time points examined thus far. The study authors also have accompanying qualitative findings that show the trade-offs of the study participants, often having to decide between paying for food and paying for other household necessities such as electricity and water. Ultimately, the study provides an exciting example of exploring the role of a policy addressing the key social determinants of health in helping to shape health and food insecurity. So to end, I wanted to highlight the NIH's Unite initiative, which has it launched to identify actions to end structural racism and racial inequities throughout the biomedical research enterprise. And as part of Unite, the NIH is setting aside a large amount of funding to support transformative research to address health disparities and advance health equity. And a part of ending racial inequities in biomedical research will be to ensure that NIH supported research benefits the health of all populations, especially those whose health is negatively impacted by racism. And for this reason, conducting new research into health disparities, minority health, and health equity is an important goal of this initiative. So while this initiative isn't specifically focused on nutrition, it certainly is related to considering the topics covered in today's lecture. So I thought that I would highlight this initiative within NIH. So to close, I just wanted to highlight some essential takeaways. So again, social determinants of diet and health include these 5 different major factors. So those are economic, education, social and community context, neighborhood and built environment, and then quality of healthcare. And then also, nutrition-related health disparities are really a result of this interrelationship and interconnectedness between these variety of social factors highlighted. And to end, to achieve nutrition equity, comprehensive and holistic programs and policies are needed to address the root causes of these disparities and not just those related to food policy alone. So the hope is at the end of this this webinar that it shed light on the complexities of nutrition-related health disparities and really the influence of social determinants of health and the underlying root causes that perpetuate these disparities. So thank you for your time, and I'm happy to take questions, and I will put my video on during this Q&A period.
Well, thank you so much, Allison, for that comprehensive talk and about really the overwhelming multi-level effects that are compounding this this history of inequities across the board. So I barely know what a question to ask you. One, because you provided so many answers to why. So I think, in public health, we are very often thinking about, okay, so what do we do? Our students often jump directly to solving a problem, and I love that part about them, that they see the problem and then they want to solve it. And so I know that we have to spend some time reflecting on these structural and interpersonal and systemic level factors that are overwhelming us in every attempt, especially those of us who have worked on sort of the service end and providing services to the communities, that it seems like an absolute uphill battle every time, because there's just something else that is much stronger, whether it's the food industry, the tobacco industry, or the fossil fuel industry that is pushing much harder against what we'd like to achieve. But in the interest of solving problems, or at least facilitating a change, I see that Professor Michelle Green had a question that was similar to something that I had also been thinking about. So how can we at the college level encourage students of color to consider becoming RDs or public health professionals, or enter the health sciences professions? And what can also, at the larger organizational level, what can the nutrition associations or interest organizations of those professions do to reverse or upset the current trends?
Yeah, so great question. I think I'll start off with, encouraging students to go into public health fields. I feel like we need more change agents in the field, with these issues, which, are longstanding. I think just having a stronger, more diverse workforce to tackle these issues and finding what makes you tick and what's passionate for you, I think is key, whether or not you want to work at a city level public health department, or you want to work at in the nonprofit sector, or you want to go kind of at the higher level, at the federal level, or work on the Hill in terms of advocacy. Those are all places where public health professionals need to be inserted. So you think of a non-traditional career path for a public health professional would be, going in and working in advocacy, whether at a nonprofit organization or on the Hill, and getting congressional experience. So I think the more advocates that we have in many different sectors is going to be important to really address these issues. So, I think it's an exciting time to be in public health, and more of, the excitement and vigor of the new generation is going to be important to tackle the issues. So I think it's key is just finding what you're passionate about and what your students are passionate about, and nurturing that, in the academic setting, I think is important. And even though it's an uphill battle, I think, we are in a moment in our country's history with everything that has happened last year with the murder of George Floyd and numerous others. And unfortunately, that continues today. There is this wave and motivation internally as a country to, even though there is some pushback, I think there is some momentum in this moment in this country's juncture. I think there was another question around what can professional societies do, nutrition societies, and I would say focusing on, helping to support students of color that are in the field, and obviously for the dietetics field in particular, the master's mandate upcoming is, very much a barrier. Um, but I think training those who are in the pipeline now, who are very, very motivated about staying in the dietetics profession, is going to be key. Diversifying the field, obviously, but also providing the supports necessary for those dietetic interns. And unfortunately, a lot of interns are often, depending on what city you do your rotation in, one of the few BIPOC members in your cohort. So realizing that that is a quite isolating experience, I think professional societies could do a better job of connecting students of color. But then also member interest groups within this NOBADAN within the academy is a way to find support. So just as an example, when I was in Boston in grad school for my PhD, I found it a very much isolating experience. I got connected and got involved with the NAACP. I got involved with NOBADAN through the academy. So finding kind of those safe havens and these safe spaces to share your experience and feel comfortable, I think that's important. And then for non-BIPOC educators, just ensuring that you listen to your students, validate their experiences if they do share with you that they're facing any discomfort or so forth. I think it's important to have those difficult conversations. Another aspect, the Academy does have a space on their website to submit any complaints of discrimination or, ethical challenges. So I would recommend, as from the student perspective, utilizing that resource, since the Academy, I'm sure, is, wanting to hear those issues that arise as well. So, there's much work to be done on the professional societies front, but I do think we're at a moment again in the country's history, and which has been the impetus for a lot of organizational change at this juncture.
Thank you. Thank you so much. I really appreciate that. And I think we also have to encourage the faculty who do have, and I know we hear a lot of those stories, to be that we become the ones to also report these experiences to the Academy and to each other, because I think there's a critical mass of experiences that we may hear independently, but that are not broadcast. And so I think it's really important for faculty allies of BIPOC students and our graduates to to help facilitate also and support this elevation of these topics. So I have one of my students, Eritrea, asked the questions about how can communities of color have more supermarkets in food desert areas, and how can we, the community, have a say on what food industry can be allowed into our neighborhood?
Yeah, I think that's an excellent question, Eritrea. And I would say get involved with your local government. Contact your representatives. Whether that be at the state level or even at the national level. So really be an advocate for yourself and your community in that way. But one person can't do it. So there are a lot of different food policy councils arising in many different cities. So I would recommend using that as a route, and then potentially organizing kind of a petition to submit to your local city officials, and then obviously at the higher level as well. But I think, it is easier to kind of tap into an organization that's doing that type of advocacy work. Again, when I was in Boston, there was a food policy council for the city. So there might be something comparable in New York City. And I know there's one in the DC area as well. So being involved and active in those type of organizations. And, the challenge too, if you're passionate about these issues, you might be stretched very thin. And if you're a student, that is a time to get more active, but depending on all the other things on your plate, you may not have the time. So I would recommend, getting initially tapped in, hopefully being as engaged as possible. But if not, you would be added to their listserv, so at least you could stay abreast to activities that are happening in those type of city level councils. And then you might be able to sign a petition or, just get more involved in that way, depending on, your time constraints and so forth. But I think getting engaged in your local government is a great first step, or any food policy councils that are in your community.
Well, thank you. So then we have a more specific data question from Professor Caviglia, who's in our department and also on the research committee. Why is the mortality rate for Hispanic populations lower than for Black and white populations?
Yeah, so that's a great question. And, there's something called the Hispanic paradox. And, and even though not mentioned, foreign-born Blacks and Black immigrants actually have better health outcomes than their US-born counterparts. So that's a limitation of the data presented as well, not being able to represent the heterogeneity within those racial ethnic groups. But with the Hispanic population, particularly a large number being immigrants, that social support and the kind of the cultural background of the importance of family and support, that may play a role into it. But then also this better adherence to the cultural diets of those of Hispanic descent. But again, when you look at the data too, among Hispanic subgroups, Puerto Ricans, for example, Dominicans aren't doing as well as their Mexican American counterparts. So really, it is important to look at data a little bit more at a more granular level. But in general, because of the larger immigrant population among the Hispanic ethnic group, that could be playing a role into it. And this kind of adherence to cultural backgrounds and diets. And that's why I mentioned kind of the cultural challenge in the US is actually Western culture and Western food, not the diets of the immigrant groups. When you think of, and just to get personal, my dad is from Trinidad and Tobago. So when I think of the foods from Trinidad and Tobago, yes, they have some unhealthy foods, but a lot of it is, based in fruits and vegetables. When I was going to Trinidad, eat mango very regularly, and different fruits and bananas, so fruit and vegetables are very much a part of the cultural cuisine. So again, I think that there's this protective aspect of being an immigrant, but again, key is holding on to your cultural background and dietary practices instead of going through this acculturation process and adopting Western cultural and dietary aspects.
Thank you.
Thank you so much, Dr. Brown. Yeah, so any other questions? We're beginning to be a smaller group. So any other outstanding questions? I see Wisha is in the meeting, Margaret and Dejanay. Wendy, if you would like to turn on your mics and ask a question, please feel free to do so. And while you warm up to that, I know that sometimes takes a few seconds. I wanted to tag on to the question from Eritrea about the food environments and sort of what can you do. To just say that in New York City, we have the Mayor's Office of Food Policy, and they have come forward with a very progressive plan for changing food environments in New York City. But obviously, it's an uphill battle, again, that requires a lot of community input. So I absolutely second Dr. Brown's suggestion. The first unit to go to is the community board, and then sit in on meetings at the community board and sort of push this onto the agenda of the community board that may have, as Dr. Brown also illustrated, many other competing interests in terms of housing inequality, in terms of income inequality, in terms of policing inequalities. And so food is just one piece of that puzzle, but definitely, and organizing, I think, between communities to sort of create critical mass. Any other questions on the chat? So I had also I wanted to hear a little more about, if you can talk about the new initiative that you mentioned, that the RFAs are coming out in terms of really addressing these inequities and that are disproportionately affecting our minority communities. Can you talk a little bit more about, like, what would be your dream project in the last minute?
Yeah, that's a great question. Again, because of the multifaceted nature of these inequities that we see, my dream, I guess, initiative would be focusing on collaborating with not only the public health department, but also the Department of Commerce in your area, also Department of Transportation, also, housing, to really have this consolidated approach within these different sectors. But obviously one grant application may not be able to have enough time to develop those relationships necessary to pull together a proper RFA. So that's why it is important, if you're a researcher in this area, to start now with trying to build those connections and not wait until an RFA comes out. So start building those connections now, getting engaged in your community, so then when a call for application arises, you'll have that information ready and those partnerships ready. So I'm in the chat box, I shared the link to the Common Fund initiative that I'm one of the coordinators for. And the topic is transformative research to address health disparities and advance health equity. We actually had a webinar right before this event, but the recording will also be available. So I would recommend looking more closely at the RFAs. There is an RFA specifically for institutions serving minorities with a certain percent, 25% or more, with Pell Grant recipients. So I'll include a link again of that specific RFA in the chat box for you to review. It is a short turnaround, but I would say, if you are an active researcher, to stay abreast of these different RFAs that are released out of the NIH, and keep abreast of the happenings so that you could be ready and armed to prepare an application during the relevant application cycle.
Well, thank you. We got work to do, but that's
Yes.
very exciting.
Yes. So I want to also thank the organizers again, and Marguerite, you for coordinating this. It's really been great to present on my work, and just thoughts really on the state of where we are in terms of that intersection between social determinants of health and nutrition. So hopefully you found the talk interesting, and it spurs you to want to learn more about these topics.
Well, Dr. Brown, thank you so much. I cannot believe the breadth and depth of what you're able to introduce to our students and faculty today, and how nutrition is so much more than what's on your plate. So thank you again to everyone who attended. Thank you for the questions. And Dejane, I see your question. I want to be cognizant of people's time. So I will definitely address that following up with you. So again, thank you for everyone who attended. I appreciate the depth again of the information, and I look forward to posting the video online so that people who are unable to attend today can do so in the future. So thank you again for joining, and thank you, Dr. Brown, and everyone who was here. I hope you have a wonderful day, and I do hope it's also spring weather where you are.
Yes.
And that you can all get outside, even for 5 minutes. So thank you, and have a great day.
Thank you.